Hi, good morning, doctors. Today we are on a 34th day of reading Oxford Handbook of General Practice. I am Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. We are at page number 583. We are reading the chapter Dermatology, and we are in the topic seborrheic dermatitis. Let's start reading. Seborrheic dermatitis, chronic scaly eruption affecting the scalp, the face, or the chest. Differential diagnosis can be psoriasis, rosacea, contact dermatitis, fungal infection. There are 5 patterns to it. Scalp and facial involvement. Most common in young men, excessive dandruff, itchy, scaly, erythematous eruption affecting the sides of the nose, the eyes, the ears, the hairline. May be associated blepharitis. Petaloid. Dry, scaly eczema over the pre-sternal area. Malassezia folliculitis, Pityrosporum folliculitis, erythematous follicular eruption with papules and pustules over the back. Flexural, most commonly in the elderly, axillae, the groins and submammary areas are most commonly affected. Moist intertrigo associated with secondary candidal infection. Infantile seborrheic eczema, page number 833. Treatment. So there are 5 types of seborrheic dermatitis. To summarize, scalp and face involvement, petaloid involvement involving the sternum. In males, Malassezia folliculitis, the back, flexural, elderly people in the axillary, groin and submammary areas, and infantile seborrheic dermatitis, which we will see in 833. Treatment. Facial, truncal or flexural involvement. Ketoconazole 2% shampoo 2 times per week for 2 to 4 weeks. Rinse off after 3 to 5 minutes. Or clotrimazole or miconazole cream plus hydrocortisone. Consider itraconazole 200 mg OD for 7 days or fluconazole 50 mg OD for 2 weeks if not clearing. So first you have to try ketoconazole shampoo for face, trunk and flexural involvement, and or a clotrimazole miconazole cream for 2 weeks, and or then if not clearing, consider itraconazole for OD for 7 days or fluconazole 50 mg OD for 2 weeks if not clearing. Scalp lesions. Ketoconazole 2% or coal tar shampoo. If resistant, apply 2% sulfur plus 2% salicylic acid cream several hours before shampooing. Recurrence. Requiring repeated treatment is common. Consider maintenance treatment with topical antifungal every other week. So, every alternate week you have to use a topical antifungal shampoo for preventing recurrence. Severe or recalcitrant seborrheic dermatitis is an indicator for HIV infection. Offer a HIV testing. Dandruff. Exaggerated physiological exfoliation of fine scales from an otherwise normal scalp. More severe forms merge with seborrheic dermatitis and treatment is the same for both. Further information, you can visit these websites. Page number 584, ulcers. Leg ulcers. Painful and debilitating condition affecting 1% of the adult population, 4% of those more than 65 years. Common causes could be venous ulcers. Above the more common location is medial and lateral malleolus of the ankle. At the medial or lateral malleolus of the ankle. Mixed venous or arterial ulcers 10 to 20%, arterial ulcers 10% on the shin, the toes or over the pressure points under the heel or over the malleoli. These are the common locations. Neuropathic ulcers on the sole of the foot or over the pressure points. Rarer causes could be trauma, obesity, immobility. Vasculitis can cause ulcers, rheumatoid arthritis, SLE and PAN, malignancy, osteomyelitis, blood dyscrasias, lymphedema and self-harm. All of these can cause ulcers. History. Duration of ulceration. Pain. Painful unless neuropathic when often painless. Mobility. Drugs causing ulcers. Example nicorandil or impending healing. Example beta blockers, immunosuppressants, NSAIDs. Past history of ulceration, DVT or varicose vein surgery. History of trauma to the limb, systemic disease, example diabetes, peripheral vascular disease, rheumatoid arthritis. So causing duration of ulceration, painful or painless, mobility, any drugs they are taking causing the drugs causing ulcers could be recurrent, impairing healing, beta blockers, immunosuppressants, and NSAIDs. Any past history of ulceration, previous ulceration, DVT is there, varicose vein surgery is there, history of trauma to the limb, systemic diseases like diabetes, peripheral vascular disease, and rheumatoid arthritis, you have to find out. Examination. The ulcer, position, size, depth, evidence of infection surrounding callus, typical of neuropathic ulcers. Callus is typical of neuropathic ulcers. Leg, pulses, varicose veins, or signs of venous hypertension like hemosiderin pigmentation, varicose eczema, atrophy blanche, white lacy scars, lipodermatosclerosis sensation, whether it is decreased when there is peripheral neuropathy, and range of joint movement. These are the things you have to check in examination. Then investigations, bloods. You will do a full blood count, ESR, FBG, fasting blood sugars, HbA1c, LFTs, urea electrolytes, EGFR, thyroid function test, lipid profile. Also, ankle brachial pressure index should be done because this will help in treating venous ulcers with compression bandages if the ankle brachial pressure index is okay. Swab for microscopy and culture sensitivity, any kind of cellulitis or infection is present. If it is a diabetic ulcer, if the infection, X-ray foot to exclude any osteomyelitis. In case of diabetes, you need to do an X-ray to the foot to exclude any osteomyelitis. Management. Refer for diabetic foot ulceration to foot clinic. Apply dressings. Choice depends on whether the ulcer is healing process, whether it is infected or the amount of exudate. Depending on the ankle brachial pressure index, consider compression therapy or referral for vascular assessment. With a multi-layer compression, 70% of the venous ulcers heal in less than 3 months. If not improving in 3 months or not healed by 12 months, refer for tissue viability service or dermatology. So, if the ulcer is not improving in 3 months with multi-layer compression bandages, or not healed by 12 months completely, refer for tissue viability services. Complications of ulcers, infection. Treat with systemic antibiotics if advancing ulcer edge, cellulitis or systemic symptoms. Antibiotic choice is guided by the swab results. Overgranulation. Treat with silver nitrate cautery or potent topical steroid, example Dermovit. Contact dermatitis. 2D topical medicaments and dressings. Treat with topical steroid and consider referral for patch testing if suspected. Malignant change. Squamous cell carcinoma, very rare, refer urgently to be seen within 2 weeks for biopsy to confirm the diagnosis. If prevention of recurrence. 5-year recurrence rate is 40%. Graduated compression, hosiery, decreases the recurrence. Uh, Below the knee, class 2 stockings are adequate and can be prescribed with NHS prescription. They can be difficult to apply, especially with arthritic hands. Applicators are available on NHS prescription. Consider referral for vascular surgery to review and assess whether a vein surgery may decrease the recurrence. If there's a varicose vein and these are varicose ulcers, then you need to refer to vascular surgery to find out if there is venous surgery can decrease the recurrence of ulcers. Ankle brachial pressure index 1.2, more than 1.2 means calcification of the vessels is likely. Refer for vascular assessment. See, there are two sides of a ABPI measurement. If more than 1.2, also you have to refer for vascular assessment because there is calcification of vessels. Less than 0.6 suggests arterial disease and refer for vascular assessment, not suitable for compression therapy. Also, 0.6 to 0.8 suggests mixed vascular disease. Consider referral for vascular assessment. Most can be managed with reduced compression therapy. 0.8 to 1.2 suggests venous disease. Leg ulcer with a ABPI 0.8 to 1.2 suggests a venous disease suitable for full compression therapy unless diabetes or rheumatoid arthritis. So 0.8 to 1.2 is the normal range for ABPI. Anything more than 1.2 is also abnormal. Anything less than 0.8 also shows ischemia. So ABPI can be falsely high in rheumatoid arthritis and diabetes. Extra care is needed when using compression therapy. Consider early referral for specialist advice. So even when there is a leg ulcer, venous ulcer, leg ulcer with 0.8 to 1.2 of ABPI and the patient is diabetic or rheumatoid arthritis is present, you need to refer them to vascular therapy for finding out whether it is spuriously high ABPI or normal. Pyoderma granulosum, uncommon in cause of ulceration, starts as a pustule or inflamed nodule that breaks down to form an ulcer that often expands rapidly and is painful. Look at this ulcer. Okay, it has a purplish margin, undermined edges. The ulcer has a purplish margin and surrounding erythema. So look at the erythema, usually on the trunk and lower limbs. Refer to dermatology. Causes are ulcerative colitis in 50% of the cases with pyoderma gangrenosum, Crohn's disease, rheumatoid arthritis, Behcet syndrome, multiple myeloma, monoclonal gammopathy, and leukemia. These are the causes. Usually found on the trunk and the lower limbs. Pyoderma gangrenosum. Bed sores or pressure ulcers. Caused by pressure necrosis of the skin, immobile patients are at high risk, especially if frail plus incontinent. If at risk, refer for the DN for advice on prevention and protective mattress, cushions, incontinence, guidance on positioning or movement. Warn the carers to make contact with the DN if a red patch does not improve after 24 hours after relieving the pressure on the area. So if there is a red patch in a particular dependent area and it is not improving after relieving the pressure on that area, you have to contact the DN. Treat aggressively and admit if not resolving. Urticaria and angioedema. Anaphylaxis, page 1054 we will see. Urticaria, hives or nettle rash. Common. Affects 1 in 6 at some time. Superficial itchy swellings of the skin or wheals come and go in an attack, giving the appearance of a shifting rash. Urticaria, hives or nettle rash commonly affects 1 in 6 at some time. Superficial itchy swelling of the skin or wheals come and go in an attack, giving the appearance of a shifting rash. Angioedema, deeper, long-lasting swellings, painful rather than itchy. These are painful rather than itchy, commonly affecting the eyes, the lips, the genitalia, hands or feet, may affect the bowel, abdominal pain, nausea, vomiting, diarrhea, or the airway, tongue swelling, shortness of breath, wheeze, consider anaphylaxis. Angioedema can, if severe, can you need to consider anaphylaxis. Page 1054. Classification. Table 16.7. Half present with urticaria alone, 1 in 10 has an angioedema alone, and the remainders have both. Management of acute urticaria. Only treat if needed. Try an antihistaminic for the itch, non-sedating for daytime, cetirizine, fexofenadine plus sedative if interferes with sleep, example chlorpheniramine and hydroxyzine. Many dermatologists use up to 2 times the standard dose. If one of the antihistaminic is ineffective, try another. Topical menthol 1% cream is an alternative or adjunct to antihistamines. If severe, consider short course of steroids, example prednisolone 40 mg OD for 3 to 5 days. So if you are considering it's a severe episode of acute urticaria, use a short course of steroids, prednisolone 40 mg for 3 to 5 days. If rebound symptoms occur after stopping, seek a specialist advice. So that could be a delayed reaction. Management of chronic urticaria. Check FBC. Check the full blood counts, ESR, thyroid function test. Assess the severity impact of symptoms. Identify potential causes. Advise to avoid non-specific aggravating factors like overheating, stress, alcohol, aspirin, codeine, and NSAIDs if aspirin sensitive. Prescribe antihistamines as for acute urticaria. If these measures do not control the symptoms, refer. Other treatments are usually specialist initiated and unlicensed. They include H2 receptor antagonists like cimetidine or ranitidine and anti-leukotrienes, example montelukast. Very responses very highly variable. So management of angioedema. If anaphylaxis is suspected, give adrenaline and admit. So angioedema, if you are suspecting anaphylaxis, that is there is any kind of systemic symptoms, Give adrenaline and admit. If airway compromise, admit, even if anaphylaxis is not suspected. Otherwise, treat for as for acute urticaria, monitor for airway compromise. If not taking an ACE inhibitor, refer to allergy clinic or immunology. If the patient is not taking an ACE inhibitor and he has developed angioedema, refer to allergy clinic or immunology. If he is taking an ACE inhibitor, stop. Refer if the symptoms continue or recur after 3 months. Urticaria pigmentosa, cutaneous mastocytosis, appears in infancy, usually less than 2 weeks old. Dark freckle-like lesions on the face, the limbs or trunk become urticarial when the skin is rubbed. No treatment is needed. Clear spontaneously in childhood. So there will be dark pigmented lesions. When they are rubbed, they become reddish and urticarial. Typical urticarial lesions in a child. Classification of urticaria and angioedema. Ordinary or idiopathic. Spontaneous wheals plus angioedema. Individual wheals last 2 to 24 hours. Acute less than 6 weeks of continuous activity. Chronic more than 6 weeks of continuous activity. Affects 1 in 5, 1 to 5 per thousand. May remit or relapse. Relapses are triggered by illnesses, stress, drugs, alcohol, hormonal changes like menstruation. 50% resolve in 3 to 5 years. 20% persists more than 10 years. Associated with autoimmune thyroid disease. 2 times risk is increased in autoimmune thyroid disease. Children or adolescents have high prevalence of increased prevalence of celiac disease. If it is present in children or adolescents, then there is increased prevalence of celiac disease. Severely impact quality of life. 14% develop depression. Episodic urticaria. So first one is acute. Second one is chronic, lasts longer and associated with autoimmune thyroid disease or prevalence of celiac disease. Episodic, acute, intermittent or recurrent. Symptoms last hours or days but recur after months or years. Treated like a chronic urticaria. Triggers include stress, overheating, drugs, alcohol and viral infections. These are the triggering factors for ordinary or idiopathic urticaria. Physical urticaria. Except for delayed pressure urticaria, wheals last less than 1 hour, induced by a specific physical stimulus. Avoidance prevents attacks. Mechanical, delayed pressure urticaria, wheals appear in 2 to 6 hours and fade over 48 hours. Symptomatic dermographism, vibratory angioedema. These are the varieties. Symptomatic dermographism, vibratory angioedema. Thermal, cholinergic urticaria induced by sweating. So this urticaria is induced by sweating. Cold contact urticaria and localized heat urticaria. Others, aquagenic urticaria in contact with water, solar urticaria or exercise induced anaphylaxis. These are because of physical stimulants. Contact, wheals lasting less than 2 hours, caused by allergens, example nuts, shellfish, milk, eggs, penicillin, insect stings, latex, or chemicals like drugs, opioids, and aspirin, NSAIDs, radio contrast media, food additives, azo dyes, preservatives. Refer for allergy testing if a specific allergen is suspected. So, this is contact urticaria, either by allergen or chemical, radio contrast media, food additives. So you have to check what is the specific allergen and avoid that. Urticarial vasculitis. Individual wheals last more than 24 hours. Lesions are burning or painful rather than itchy, and the lesions have scaling, bruising, purpura or petechial hemorrhages. Suspect if relentless rather than self-limiting urticaria. Other features are joint pains, fever or malaise. Refer. Diagnosis is confirmed by skin biopsy, specialist treatment, steroids and or immunosuppressive agents. So, arterial vasculitis. Whenever there is vasculitis, you have to give immunosuppressant agents, steroids or immunosuppressant agents. And diagnosis will be by skin biopsy. Other features, because they will have systemic symptoms like joint pains, fever and malaise. Autoimmune. Urticaria, pyrexia, malaise plus disease-specific features may be hereditary or acquired like in SLE. Treat cause. Lone angioedema, swelling lasting less than 3 days. Causes are idiopathic drug-induced ACE inhibitors, ARBs, and SAIDs, C1 esterase inhibitor deficiency. So this is lone angioedema without any urticaria. C1 esterase inhibitor deficiency or hereditary angioedema is an autosomal dominant condition, usually presents in puberty with episodes of angioedema without wheals. Decrease in C4 level suggests the diagnosis. Emergency treatment is hospital admission for C1 inhibitor concentrate infusion, maintenance therapy under consultant supervision with anabolic steroids or tranexamic acid. Is necessary only for patient with symptomatic recurring angioedema or related abdominal pain. So, maintenance therapy for C1 esterase deficiencies with anabolic steroids or tranexamic acid is necessary only in patients with symptomatic recurring angioedema or related abdominal pain. So, the next topic in dermatology is acne. It's a very common symptom in general practice. Chronic inflammatory conditions characterized by comedones, papules, pustules, cysts, and scars. Acne vulgaris is common and affects more than 80% of the teenagers. 50% of them have family history. Peak age is 18 years and same male to female ratio is same. So at least 80% of the teenagers will have acne. Cause. Complex androgen secretion results in increased sebum production, pilosebaceous duct blockage producing comedones, colonization of the duct with Propionibacterium acnes bacteria, and release of inflammatory mediators. Inflammatory acne is the result of host response to follicular Propionibacterium acnes. So, it's it has various pathophysiology. Rarer causes are endocrine causes of acne, PCOS, Cushing syndrome, virilizing tumors, squeezing, acne excori, aromatic industrial chemicals like chloracne, cosmetics, drugs, systemic steroids, androgens, topical steroids, infantile, faces of male infants, cause is unknown, physical occlusion, example under a violinist's chin. Presentation. Spots on the face and neck plus back or chest. A re-examination reveals blackheads, dilated pores with black plug of keratin exam is equal to comedones. And whiteheads, small cream-colored dome-shaped papules. Red papules, pustules plus cysts. There may be scarring from old lesions, burrowing plus abscesses and sinuses with scarring, conglomerate acne. So there is burrowing, abscesses and sinuses with scarring. Conglomerate acne are seen in severe cases. Scars may become keloidal. Severity of acne is often overestimated by the patient and minimized by the doctor. Differential diagnosis could be rosacea, bacterial folliculitis often coexists, milia or perioral dermatitis. Management aims to decrease the number of lesions, prevent scarring, and decrease the psychological impact of the condition. Misconceptions. Explain the patient. Acne is not a disease of poor hygiene and it's not infectious. The black tip of a comedone is oxidized sebum, not dirt. A high glycemic index diet may be associated with acne, so suggest decreasing the sugars and increase whole grains and fresh fruits and vegetables. Peeking at acne does not improve it and it can cause scarring. General measurements encourage to wash no more than 2 times per day using a fragrance-free cleanser. Recommend non-comedogenic makeup. Avoid oil-based cosmetics and emollients. Medication. Table 16.8. Warn the patient any treatment takes up to 8 weeks to work and it may irritate the skin initially. The topical and systemic antibiotics should not be prescribed together or used as a sole treatment as antibiotic resistance is a growing concern. All treatment should be routinely reviewed after 12 weeks. In the event of pregnancy, all retinoids and oral tetracycline should be discontinued. Review. If the treatment goals are met after 12 weeks, discontinue topical or oral antibiotics and consider maintenance treatment with topical therapy. If treatment goals are not reached at 12 weeks, review the treatment adherence and consider alternative treatment or referral. Acne treatment ladder. This is stepwise treatment of acne. Step 1. Comedomal acne. First line. Topical retinoid. Isotretinoin, adapalene or benzyl plus or minus benzyl peroxide. So retinoid plus benzoyl peroxide. Start with low strength preparation 2 to 3 nights per week. Gradually increase the frequency, the duration and the strength of the preparation. While the patients the treatment may dry, irritate the skin initially and to avoid sun exposure. Second line treatment is topical azelaic acid, skinoren or finacea. So first one is topical retinoid, isotretinoin adapalene or topical azelaic acid. Step 2. Mild to moderate papular or pustular acne. Try a fixed dose combination topical treatment. First line. So the first one was only comedomal acne. Second one is mild to moderate papular or pustular acne. Try a fixed dose combination of topical treatment like adapalene plus benzoyl peroxide, Epidio. Second line is clindamycin plus benzoyl peroxide, Duac. Other options clindamycin plus tretinoin, Triclin or erythromycin combinations. Warn the patients that the treatment may dry irritate the skin initially and avoid the sun. Step 3. Treatment failure and more extensive acne. Combine oral antibiotics with topical agent, usually benzoyl peroxide, but consider other topical retinoid if unable to tolerate benzoyl peroxide. First line, Limicycline 408 mg OD, review after 6 weeks. If an inadequate response, switch to doxycycline 100 mg OD may cause a photosensitive reaction. Alternatives if pregnant or less than 12 years of age. So in less than 12 years we are not giving tetracycline. So and if pregnancy is there, erythromycin or trimethoprim. Continue treatment for a maximum of 12 weeks only, that is 3 months. Continue topical treatment once antibiotics is stopped. Course of antibiotics can be repeated if acne recurs. Step 4. Moderate to severe acne. In This is in females. Consider hormonal contraception with a second or third generation combined oral contraceptive pill. Cocyprindol. Has a little androgenic effect. Anti-androgenic effect is reserved for females whom other treatments have failed. Discontinue after 3 months after acne control is achieved. Discontinue 3 months after acne control is achieved. Complications. Acne is not a trivial disease. It causes scars, both skin and emotional, and lasts a lifetime. Anxiety and social isolation and lack of self-confidence are common. Ask about these factors, treat as needed. Perioral dermatitis. Papules, this is another topic. Papules, pustules which appear around the mouth and chin of a woman, often after use of topical steroids. Treat with oral tetracyclines as for acne. So perioral dermatitis is after topical steroids use and you need to treat with an antibiotic. Referral to dermatology. Acne fulminans seen in adolescent boys, severe acne associated with severe arthritis, fever and vasculitis. Urgent referral. Nodulocystic acne for consideration of oral retinoid. Start oral antibiotics and refer immediately. Urgent referral. So retinoid has to be started by a dermatologist. So whenever you are seeing nodulocystic acne, that is severe acne, then you start an oral antibiotic and refer to a dermatologist for starting retinoid. Severe social and psychological sequelae, urgent referral. At risk of developing scarring despite primary care remedies, routine referral. Poor treatment response after more than 6 months, routine referral. Suspect underlying cause for acne like PCOS, routine referral. Diagnostic uncertainty, routine referral. Page number 590, psoriasis. Chronic non-infectious inflammatory skin condition. The epidermal cell proliferation rate is more than 20 times and the turnover time is less from 28 to 4 days. So skin turnover time is reduced from 28 days to 4 days and epidermal cell proliferation is also increased. So affects 3% of the Caucasian population, less in other races. Mean age is 28 years, rare in less than 8 years. Male to female ratio is same. Associations associated with inflammatory bowel disease, cons more than ulcerative colitis. Increased risk of, so it's a non-extraintestinal manifestation of Crohn's disease. Increased risk of CVD, cerebrovascular disease. Check the blood pressure, lipids and exclude diabetes. Causes autoimmune diseases, genetic predisposition, family history is present in 40 to 50% of the cases with psoriasis, 75% if the onset is at age less than 20 years. So 75% genetic history if onset is less than 20 years. If one parent is affected, there is a 28% probability the child will be affected and 65% chance if two parents are affected. Environmental factors trigger disease, trauma, Cobnus phenomenon, infection, alcohol, pregnancy, psychological stress, drugs, beta blockers, NSAIDs, lithium, Sunlight usually beneficial but aggravates psoriasis in 10% of the patients. Presentation. Two peaks of incidence, young adults and those aged 60 to 70 years, generally presents with skin changes but no other symptoms. Skin changes may be accompanied by an itch. Patterns of psoriasis, table 16.9, we will see that. Assessment. All patients with psoriasis should be assessed at least once in a year, and if any new or worsening symptoms are present, consider percentage of the body surface area affected, involvement of the nails, 50% of the cases, global disease severity rating from clinician and patient's perspective, clear, nearly clear, mild, moderate, severe or very severe. Presence of arthritis affects 14 to 30%. If no arthritis, screen with the PEST questionnaire annually. Box number 16.2. High impact or difficult to treat sites like face, the scalp, the palms and soles or flexures or genitals. So difficult to treat sites, face, scalp, palms, soles, flexures and genitals. Impact of disease on physical, psychological and social well-being. Impact on the patient, family and carers. Consider depression screening. Presence of comorbidities including CVD risk assessment, systemic upset, fever and malaise may indicate unstable psoriasis requiring admission. So in a patient with psoriasis, if they are developing fever and malaise, which is not non-infectious cause associated with disease progression, requires admission. Management of psoriasis, page 592. Box 16.2, psoriasis epidemiology screening test. PEST. Have you ever had a swollen joint? This is for checking about the arthritis, psoriatic arthritis. Have you ever had a swollen joint or joints? Has a doctor ever told you that you have arthritis? Do your fingernails or toenails have holes or pits? Have you had pain in your heel? Have you had a finger or a toe that was completely swollen or painful for no apparent reason? Score 1 point for each positive answer. A score of more than 3 indicates high risk of psoriatic arthropathy and should prompt dermatology referral. Does not detect axial arthritis or inflammatory back pain. So PEST screening tool is for psoriatic arthropathy. 16.9, pattern of psoriasis. The pattern, erythroderma, is more than 90% of your body surface area is red. This erythroderma admit as a medical emergency. Generalized pustular psoriasis, rare but serious, unwell with fever and malaise. Sheets of small sterile yellowish pustules develop on an erythematous background and spread rapidly. Admit as an emergency. Generalized pustular psoriasis. Plaque psoriasis. Most common form, 90% of the cases, well-defined disc-shaped plaques involving the knees, the elbows, the scalp, the hair margin or the sacrum. Plaques are usually red and covered with waxy white scales which may leave bleeding points if detached. Plaques may be itchy. Differential diagnosis could be a drug eruption. It could be hypertrophic lichen planus. Scalp. Very common. In the scalp, very common scalp psoriasis may be confused with dandruff but generally better demarcated and thicker scales. Gutted psoriasis will be in the figure. Acute symmetrical raindrop-like lesions on trunks and limbs, most common in adolescents or young adults, may follow streptococcal sore throat infection. Usually clears in 2 to 3 months. Differential diagnosis, pityriasis rosacea. And for both pityriasis and gutted psoriasis, it is conservative management. Flexural affects the axillae, submammary areas and natal cleft. Plaques are smooth and often glazed, most commonly in the elderly people. Differential diagnosis, flexural candidiasis. Nail. Nail bed is affected in 50% of the cases, fingernails more than toenails. Timbal pitting or onycholysis and oily patches, oily brownish yellowish discoloration of the nail bed often adjacent to onycholysis. So there will be timbal pitting, onycholysis, oily patches, oily brownish yellow discoloration of the nail bed, often adjacent to the onycholysis, associated with arthropathy. Treatment is difficult. Differential diagnosis. Fungal nail infection can coexist, so sense clipping for mycology. Palmoplantar psoriasis, plantar pustulosis. Yellow-brown color sterile pustules on the palm or soles. Yellowish or brown color sterile pustules. Napkin, well-defined eruption in a nappy area of the infants. Psoriatic arthropathy, 40% patients with skin changes. Distal arthritis, so psoriatic arthritis is distal interphalangeal joint. swelling of the hands or feet plus flexion deformity. Rheumatoid-like polyarthropathy similar to rheumatoid arthritis but less symmetrical and rheumatoid factor is negative. Mutilants also associated with severe psoriasis, erosions in the small bones of the hands or feet plus spine. Bones dissolve, progressive deformity will be there. Ankylosing spondylitis or sacroiliitis, usually HLA-B27 positive. Refer to rheumatology for confirmation of diagnosis, advice on management and disease modifying drugs. So this one is chronic plaque psoriasis on the extensor aspect of the knee, silvery scale of plaque psoriasis. This one is widespread rash of guttate psoriasis, and this one is nail changes, pitting and onycholysis in psoriasis. Management of psoriasis. Explain the condition or treatment options. Discuss the chronic nature of the psoriasis and reassure not contagious. Provide information about psoriasis and advice on self-help organizations. Assessment and regular review. Emollients. Prescribe emollients to be used continuously even when active treatment is not required. Decrease the amount of scale and itch. Topical treatments. Choice depend on the extent and site of psoriasis. Cream, lotion or gel is suitable for widespread psoriasis. Lotion, solution or gel is suitable for scalp or hair bearing areas. Ointment is preferred to treat areas with thick adherent scale. Plaque psoriasis on the trunks and limbs. So whenever the lesion is on the trunk and the limbs, you use a betamethason calcipotriol. So betamethason is a mild potency steroid and calcipotriol combination. Dovobet gel or ointment and Enstellar foam are used by many GPs for the first line treatment of plaque psoriasis. NICE recommends separate application. Discontinue when the skin feels smooth even though it still looks pink and red or after 8 weeks. So for 8 weeks you can give the steroid at a stretch. Do not restart a potent topical steroid for more than 4 weeks. Recommend ongoing treatment with an emollient plus vitamin D analog, calcitriol or calcipotriol as needed. Alternatives include tar preparation, Enorex, Exorex, lotion for large thin plaques, topical retinoid, tazarotene, co-prescribe a topical steroid applied at the same time to decrease the skin irritation. Dithranol should only be used under specialist supervision. So that is for chronic plaque psoriasis. Scalp psoriasis for the body. Scalp psoriasis, advise use of coal tar shampoo, polytar or Effosil. Apply for more than 5 minutes to allow the time to penetrate the scalp before washing out. Benzalkonium chloride shampoo, Dermax is an alternative. Treat the flare-ups with topical steroid, beta-metazone scalp application or clobetasol shampoo or topical steroid or vitamin D analog combination. Dovobet gel. Do not wash the hair for 8 to 12 hours after application of gel or scalp application. Leave the shampoo on for 20 minutes before washing out. 1% hydrocortisone or clobetasol cream may also be used to treat scalp margin psoriasis. This is scalp margin psoriasis. Hydrocortisone is a mild potency steroid and clobetasol is a moderate potency steroid. If a thick scale, try a coal tar plus salicylic acid preparation, Sepco. Massage for 5 minutes and then leave on for 2 hours, preferably overnight. Wash out with Capasol shampoo. When patient's treatment is messy, may need to cover the scalp with a shower cap or old towel or pillowcase. Facial psoriasis. Avoid potent topical steroids. Avoid potent topical steroids on the face. Try vitamin D analog. Example, tacalcitol lotion. Vitamin D analog, tacalcitol lotion or ointment or calcitrol ointment. Facial psoriasis. Lower the strength of topical steroids, that is 1% hydrocortisone or clobetasol cream may be used but carry the risk of skin atrophy. An alternative is topical tacrolimus 1% ointment off label if inadequate response. Genital or flexural psoriasis. where the skin is very thin, consider weaker steroids, 1% hydrocortisone or clobetasol, or vitamin D analogs, calcitriol or calcitriol ointment. Topical tacrolimus or pimecrolimus cream may be alternatives if inadequate response. Both off-label. More potent steroid can be used in the gluteal cleft. Hand and foot psoriasis. If hyperkeratotic, try an emollient plus diprosalic ointment. If inadequate response, a stronger salicylic acid preparation may be required, like 5% salicylic acid in yellow soft paraffin BD until the scale thins off. This is made up by the pharmacies as a special and may be very expensive. Pustular psoriasis. Try potent topical steroid like clobetasol propionate 0.05%. This is not clobetasol, this is clobetasol, which is potent topical steroid. Betamethasone 1% is potent. Application with occlusion with a cling film may increase the effect in pustular psoriasis. Nail psoriasis is difficult to treat. Distal nail involvement, cut the nail as short as possible and apply a potent steroid or steroid plus vitamin D analog combination for OD for 3 months. Nail varnish can be used to disguise nail changes. Refer if nail changes are having major functional or cosmetic impact. Gutted psoriasis usually clears naturally by 2 to 3 months. Try emollients plus Coltral preparations, Exorex lotion, Alphosil HC cream plus vitamin D analog applied directly to the lesions. If widespread or unresponsive, refer to dermatology for UVB phototherapy. So initially it should clear within 2 to 3 months on its own. If it does not clear, you start Coltach preparations or vitamin D analogs, and if widespread or unresponsive, refer to dermatology for UVB phototherapy. Review. 4 weeks after starting a new topical treatment. If inadequate response are adherent to treatment, discuss the next treatment option. If responding to treatment, advise to continue until the skin is clear or nearly clear, or up to a maximum treatment period of 8 weeks for potent topical steroids. Relapse once treatment is stopped is likely. Provide a supply of topical treatment to be used as needed and to maintain disease control. Referral. When do you refer a patient with psoriasis? Unstable psoriasis, generalized pustular psoriasis or erythrodermic psoriasis, you need an emergency referral. Acute gutted psoriasis requiring phototherapy, urgent referral. So, all children less than 16 years, urgent referral or soon referral. Immediately, if topical therapy alone is unlikely to control symptoms, example extensive, more than 10% of body surface area is involved, moderate or severe, or nail disease with functional or cosmetic impact, soon or routine referral. So there is extensive lesions in the body, more than 10% body surface area, moderate or severe disease or nail disease with functional cosmetic impact, you need to refer. Severe physical, social or psychological sequelae, soon referral. For management of associated arthropathy to rheumatology, soon referral. Diagnostic uncertainty, soon or routine referral. Inadequate response to primary care treatment, routine referral. Secondary care treatment options for psoriasis is phototherapy and PUVA, ultraviolet, soral ultraviolet air therapy, oral retinoids, cytotoxic agents, immunosuppressive drugs, biological therapies, specialist nursing services. Page number 594, lichen planus and keratinization disorders. Lichen planus. Very itchy polygonal flat top papillar lesion 2 to 5 millimeters diameter affecting the flexor surfaces, the palms and soles, mucous membranes, 2/3 and genitalia in a symmetrical pattern. So it's a symmetrical lesion with planar papules, purple, pruritic lesions, flat lesions affecting the flexor surfaces of the palms, the soles, the mucous membranes and genitalia. Cobnus phenomenon, the lesions occur in the line of damaged skin due to a scratch is exhibited. Papules may have surface network of white lines, become striae. Initially papules are red but become violaceous. Papules flatten over a few months to leave a pigmentation or occasionally become hypertrophic. 2/3 of the cases occur in 30 to 60 years age group. Females and males have similar predisposition. Causes is unknown. So this is the age group, typical age group of lichen planus. Annular, commonly on the glans planus. Atrophic, rare, associated with hypertrophic lesions. Bullous, blistering is rare. Follicular may occur with typical lichen planus or just affecting the scalp. Hypertrophic, plaques may persist for years. and mucous membrane lesions alone or with skin changes. These are the variants of light chain planus. Differential diagnosis: light chain or drug eruption or psoriasis. Complications of light chain planus: nail involvement, longitudinal pitting and grooving. Scalp involvement, scarring, alopecia. Light chain planus can cause scarring, alopecia. Malignant change. It's controversial whether oral light chain planus can undergo malignant transformation. If it can, risk is low, 2% over 10 years. NICE recommends patients with confirmed oral light chain planus are monitored for oral cancer as a part of routine dental examination. Management. Emollients and moderate high potency topical steroids provide symptomatic relief. Sedating antihistamines may be useful if sleep disturbed. Oral lesions can be treated with hydrocortisone pellets. Okay, so sedative antihistamines for pruritus and oral lesions treated with hydrocortisone pellets. Rarely oral lesions are reaction to mercury amalgam fillings. Removing the fillings and replacing them with other materials may solve the problem. Refer to dermatology if diagnosis is in doubt. Extensive involvement is there, potentially scarring, nail dystrophy, resistant to topical treatment. Specialist treatment involves oral steroids plus or minus PUVA. Prognosis: 50% are clear in less than 9 months and 15% have continuous symptoms more than 18 months. 20% have a further attack. So this one is lichen planus, purple, and this is a scratch. This is Copner's phenomenon. This is oral lichen planus which becomes dry. Lichen planus like drug eruptions. Recorded after treatment with, so lichenoid drug eruptions, the drugs are thiazide diuretics, ACE inhibitors, tolbutamide, penicillamine, phenothiazine, streptomycin, tetracycline, isoniazid, gold, quinine and chloroquine. Dissolution after withdrawal of the drug is often very slow. Lichen sclerosus, hypoplastic bulbar dystrophy is page number 707. We will read there. Callosities, painless localized thickening of the keratin layer, protective response to friction or pressure. Painless localized thickening of keratin and protective response to friction pressure. Management: keratinolytics. Example: 5 to 10% salicylic acid ointment or 10% urea cream. Attention to footwear. So callosities: 5 to 10% salicylic acid, 10% urea cream. Cons: painful. Develop at areas of high local pressure on the feet. Example: where the shoes press on the bony protrusions. Management: attention to footwear, keratinolytics, cushioning, corn pads. Occasionally surgery may be indicated if deformity of the foot causes recurrent corns. Keratolysis pilaris. Common and sometimes inherited condition. Small horny plugs are on the upper thigh, upper arm and face. Keratolysis pilaris. Small horny plugs on the upper thigh, upper arm and face, given in the figure, associated with ichthyosis vulgaris, keratinocytes, ichthyosis vulgaris, keratolytics, example 10% urea cream and improve the symptoms. Keratosis pilaris. Ichthyosis. Inherited disorders characterized by dry scaly skin. Most common form is ichthyosis vulgaris, prevalence 1 in 300. Autosomal dominant. Small brany scales on the extensor aspects of the limbs and back. Brany scales, extensor aspects of the limbs and back. Mild and often undiagnosed. Management: topical emollients. Severe cases require dermatology advice. Keratoderma. Hyperkeratosis of the palms and soles. Tylosis is diffuse hyperkeratosis of the palms and soles, usually inherited, autosomal dominant, but rarely may be associated with esophageal cancer. Acquired keratoderma occurs in women around menopause and patients with lichen planus. Treat with keratolytics, example 10% urea cream. Milia. Small white raised 1 to 2 mm diameter spots resulting from small keratin filled cysts, usually on the face, upper cheeks and eyelids. Most common in children but can occur at any age. No treatment is required. So this one is keratosis pilaris. This is associated with ichthyosis. This one is milia, the small fluid filled pearly white small papules as milia. Pityriasis and seborrheic keratosis. Page number 596. Pityriasis rosea. Acute self-limiting disorder most commonly affecting the teenagers and young adults. Causes, it is self-limiting. Cause is unknown, possibly viral. Generalized eruption is preceded by a herald patch. This one is the herald patch, and see, these are the generalized eruptions and along the lines of Langer. A single large oval lesion of 2 to 5 centimeters in diameter. Several days later, a rash appears consisting of many smaller lesions, mainly on the trunk, following a ribs, giving a Christmas tree pattern, but also upper arms and thighs. Lesions are oval and pink, hence delicate colorado of scale, may be asymptomatic and mild cause mild or moderate itch. Treatment does not speed clearance. Topical steroid may relieve the itch, fades spontaneously in 4 to 8 weeks. No need to treat. If needed, topical steroids will decrease itch. Pityriasis versicolor or tinea versicolor, chronic and often asymptomatic fungal infection of the skin, Pityrosporium obriculare, common in humid and tropical conditions. In UK, often affects young adults and teenagers. In untanned and white skin, appears as pinkish brown oval or rounded patches with fine superficial scaling. In tanned or darker skin, patchy hyperpigmentation occurs. Involves the trunk and proximal limbs. Management: topical imidazole antifungals, that is clotrimazole cream BD, or topical selenium sulfide shampoo to all the affected areas at night, washed off the following morning and repeated two times a week. Shampoo will be repeated 2 times in a week. For resistant cases, try a systemic antifungal like itraconazole 200 mg OD for 1 week. Recurrences are common. Hyperpigmentation may take some time to clear. So this one is typical hyperpigmentation seen in pityriasis versicolor, showing patchy hyperpigmentation. Pityriasis alba. Finely scaled white patches on the face or arms, affects children and young adults, associated with atopy. Usually no treatment is required, resolves spontaneously over months or years. If severe, refer to dermatology for confirmation of diagnosis. Treatment for severe cases is topical steroids or PUVA. See, lightly hyperpigmented patches. Pityriasis alba on the child's face. Seborrheic keratosis or senile warts. Basal cell papilloma. Senile warts, basal cell papilloma, not carcinoma. Seborrheic keratosis. See, seborrheic keratosis will be a stuck-on appearance. Common more than 60 years, often multiple, mostly common on the trunk. Warty nodules, usually pigmented, 1 to 6 centimeters diameter with a stuck-on appearance. Is seborrheic keratosis. Pieces can be picked off. Causes is unknown. See, look at this pic. See, they look like something is stuck on, some waxy substance is stuck on, which you feel like you want to remove it, and which can be removed. So that one is seborrheic keratosis. Features of on dermoscopy. Dermoscopy requires specialized training, useful for distinguishing benign and malignant pigmented lesions. Typical dermoscopic feature of seborrheic warts or keratosis are fat fingers, irregular crypts, light brown fingerprint-like parallel structures, milia-like cysts. 2 types: tiny, white, starry, yellow, starry and larger, and yellowish cloudy. Fissures, ridges, blue-gray globules. These are all the features on dermoscopy. Okay, fissures, ridges, blue-gray globules, irregular crypts, light brown fingerprint-like parallel structures, milia-like cysts. 2 types: tiny, white, starry, and larger, yellow, cloudy. Management of seborrheic keratosis. Reassurance: if removal is required, cryotherapy, curettage, shave biopsy or excision biopsy are all effective. Seborrheic keratosis with typical stuck-on appearance. Further information, you can check the website. Page number 598. Sunlight and the skin. Skin conditions worsened by sunlight. HSV, cold sores, lupus erythematosus, porphyria, rosacea, Darier's disease. Skin conditions improved by sunlight. Acne, atopic eczema, pityriasis, rosacea and psoriasis. So improved by sunlight is acne, atopic eczema, pityriasis, rosacea and psoriasis. They improve by sunlight. Which worsen? Porphyria and SLE, rosacea. Skin cancers, page 602, sunburn, page 1097, pellagra 615, actinic keratosis. Single or multiple discrete scaly hyperkeratotic rough surfaced areas over sun-exposed sites, example dorsum of the hands, the head and neck, occasionally occur on the lower lip. More common with fairer skin types, may regress spontaneously or can be pre-malignant. So actinic keratosis is often pre-malignant. Management: examine all the skin to look for skin cancer, provide advice on UV protection, treat individual lesions with fluorouracil cream OD for 4 weeks or cryotherapy. Treat the field damage with diclofenac 3% gel. See, this is not diclofenac 1% which we use for pain relief. It is a diclofenac 3% gel which is very irritant. Imiquimod cream, ingenol mebutate gel, fluorouracil cream, depending on the size and affected area. So treat with fluorouracil cream for 4 weeks or cryotherapy. Complications of actinic keratosis: malignant change, cutaneous horn development, treat with excision or curettage, sent for histology. Either it can cause malignant change or it can cause cutaneous horn development and treat with excision, curettage, sent for histology. Solar elastosis: sun exposed skin is yellow, thickened and wrinkled. No treatment, advised to avoid sun exposure and wear a sunblock. Solar urticaria rare. Wheals appear within minutes of sun exposure. Management: sunscreen avoidance. Refer to dermatologist if disabling. Drug-induced photosensitivity. Drugs may produce light eruption in exposed areas by dose-dependent or allergic mechanisms, and reaction varies according to the drug. Common examples are amiodarone, chlorpropamide, furosemide, brizofulvin, phenothiazines, sulfonamides, tetracycline, thiazides, naldixic acid, coal tar, and plant-derived psoralens. So these are the drugs which may cause photosensitivity: amiodarone, chlorpropamide, furosemide, griseofulvin, phenothiazines, sulfonamides, tetracyclines, thiazides, tetracyclines like doxycycline, thiazides, naldixic acid, coal tar, and plant-derived psoralens. Plant-induced photodermatitis. Contact dermatitis in light-exposed areas resulting from local sensitization of the skin by contact with psoralens from plants like carrots, celery, fennel, parsnip, common rue, giant hogweed. So, these are some plants containing psoralens, natural psoralens like carrots, celery, fennel, parsnip, common rue, and giant hawksweed. Oils used in perfumes derived from these plants, example oil of bergamot, may also contain psoralens. So oil of bergamot also contains psoralens. So this one is a horn, keratin horn, and these are scalp lesions of actinic keratosis, not seborrheic keratosis, scalp lesions of actinic keratosis. This one is polymorphic light eruption. So look at the papules. This is maculopapular rash. It's polymorphic light eruption. So polymorphic light eruption: pruritic papules, plaques, vesicles appear in sun-exposed areas 24 hours after exposure. Most common photodermatosis, and females to males is 2:1. Causes unknown. Management: sunscreens and avoidance of sun exposure, sit in shade, long sleeves, trousers, broad brimmed hat. A short course of phototherapy in spring may help severe cases. Refer to dermatology. Condition is non-scarring. Differential diagnosis: airborne contact dermatitis, plant or non-plant origin. Plants are commonly caused from the Compositae family. Drug-induced photosensitivity and lupus. Actinic prurigo rare. Starts in childhood. Papules and excoriations on the sun-exposed sites. Starts in childhood. Papules and excoriation on the sun-exposed sites. Management: sunscreen avoidance. Refer dermatology for confirmation of diagnosis and advice for further management. Porphyrias, a group of rare, mostly inherited metabolic disorders. Porphyrins are important in the manufacture of hemoglobin. Deficiency of enzymes in the porphyrin pathway results in buildup of intermediary metabolites which are toxic to the skin and nervous system. All require specialist management by the general physician or a dermatologist. The main porphyrias are acute intermittent porphyria. Intermittent attacks precipitated by many drugs. Presentation are fever, GI symptoms, vomiting, abdominal pain, can be severe. Neuropsychiatric symptoms: hypotonia, paralysis, fits, impaired vision, peripheral neuritis, odd behavior, even psychosis. No skin features. Urine may go deep red on standing. So acute intermittent porphyria, the urine may go deep red on standing, and if the presentation is with there is no skin manifestation in acute intermittent porphyria. Presentation is systemic fever, GI symptoms like vomiting, abdominal pain, neuropsychiatric symptoms, and peripheral symptoms. Porphyria cutanea tarda. Most common porphyria, typically male alcoholics with liver damage, presents with fragile blisters on the back and hands of the hands with scar. Fragile blisters on the back of the hands with scar. This is porphyria cutanea tarda. Management: avoidance of alcohol and aggravating drugs like estrogens, venesection, and chloroquine. Avoidance of alcohol and aggravating drugs. Example: estrogens, venesection, and chloroquine. Erythropoietic protoporphyria is an autosomal dominant, starts in childhood, red blistering eruption leaving scars on the hands and nose. Red blistering eruption leaving scars on the hands and nose is erythropoietic protoporphyria. Variegate porphyria is an autosomal dominant condition, again common in South Africa. The skin signs are like porphyria cutanea tarda, that is blisters on the hands, which fragile blisters on the back of the hands with scar, but abdominal pain and neuropsychiatric symptoms resemble an AIP. So variegated has both porphyria cutanea tarda and acute intermittent porphyria like symptoms. So that is variegate. Erythropoietic, red blistering eruption leaving scars on the hands and nose, that is in childhood. So that's all for today, doctors. Tomorrow we will continue from page number 600, chapter dermatology, benign skin tumors. Tomorrow we will read about that. Thank you. Have a good day.